Thank you. So, good morning, everyone. Um, in this fellows teaching round, we will be conducting a tricky case of the month session, in which we can discuss four cases which has confused us, which are rare presentations, and these are kind of case reports in itself, and it had baffled us and that how to deal with it. And so, to help uh, us, we have senior faculties, Dr. Hitesh Shah. As you all know, he is chief at Manipal, and is a huge contribution to pediatric orthopedics in India. And another colleague is Sandeep Vaidya, who is a senior pediatric orthopedic surgeon from Mumbai, and he has a textbook of pediatric trauma on his credit. So thanks, Dr. Hitesh and Sandeep, for being with us today. We have four cases, and uh, fellows from Orthokids, they will present, and I'll try and moderate those sessions, those cases, and we'll take your input as we go on. So, Preksha, can we start? And these
Yes.
are interactive session. So any delegate have any question or comment, they can raise their hand, and they can ask or interrupt. Okay? Yeah,
I share my screen.
sure.
Is it visible, sir?
Yes, please go ahead.
Yes. Hello, good morning, everybody. I'm Preksha, and I'll be presenting a case. And so, so it is on how to excise invisible bars. So, a 6-year-old presented to us with left lower limb deformity and limb length discrepancy, which was progressive in nature. So, this patient sustained bilateral distal end the femur fractures about 8 months ago during a road traffic accident, which was managed conservatively. So, when you see this
So,
X-ray,
so first question is to Sandeep. If a 6 years old or 5.5 years old present to us like this with this initial X-ray, Sandeep, what would be the right way of managing it?
Yeah, so first, obviously, when the initial presentation, you have to look at the, distal neurovascular and compartment. That is the first priority that has to be there. Then we turn our attention to the, the fracture per se. So in this case, you can see that it is a, kind of a low metaphyseal fracture, probably. It's not exactly a physeal injury. However, having said that, this injury, there is still a very high likelihood of growth arrest because this can potentially damage the blood supply to the physis, especially at this age group. And at this age group, I would still go ahead with a close reduction and K-wire fixation. However, following all the rules of K-wire fixation for fixing across the physis. So the wire has to be as thin as possible, single attempt wire, low torque drill, all these, principles of fixation across the physis has to be followed. So I would probably treat this with a close reduction and K-wire fixation.
Yeah, Hitesh, what is your take on this?
I I agree with Sandeep. However, the basically the injury is more on the left side, and it is
Yes,
gone on the flexion rather than the right side is more or less is
buckle
not
kind of.
displaced.
Yeah,
Yeah, so the right side doesn't require anything. Just putting on a plaster is okay. The left side we can put into the close reduction, and I will in at 6 years it's very difficult to hold into the metaphysis to diaphysis sometimes.
mm,
So I will go ahead with the plaster, bilateral AK plaster, without doing anything in that. So you can correct mild the deformity on both plane and get it to the right,
right.
because if we take under anesthesia, then we can do the check that whether it is injury is going inside or not. We can check. Otherwise, we can put about just plaster on both sides.
Right. So, as Sandeep rightly mentioned, it's difficult to see whether there is an Salter Harris injury. I mean, what I saw that this all looks a comminuted metaphyseal fracture and at one point it is going probably near the physis, but we are not sure whether it is a physeal injury or not. And the second, if we plan to do casting, or plaster, what will be the uh, position of immobilization? Would you put it in extension, or what would you do
Yeah,
in
you can put it
extension?
in extension. Yeah, that's okay because it is in flexion, so you can put it in extension. It's okay. And the metafish is going into physis. It is described like a Peterson type 1 injury in
Hmm.
the physeal injury. So it is, there is possibility cannot be ruled out because that is the severity of the injury at the metaphysis is going to the physis actually on the
What
left side particularly.
and what I also felt is there is a comminuted injury. So in plaster, we will not be able to control this fragment. So if this patient would have come to me at one first site, can Sandeep we put a jazz fixator temporarily because this will collapse, or you will just consider K-wire and or plaster?
I would prefer K-wire because if you have to put a Jess, getting a hold in the distal fragment, you would have to put a pin into the epiphysis,
Yeah,
So
yeah,
you are
yeah. That's
breaching
what
the
I'm
joint,
telling you.
you are violating the joint. And if there is a pin tract infection, that would be a disaster. The other option is you will have to span the knee, but I think that would be an overkill. I would probably
Right.
fix this with K-wires. Another
K-wire.
thing about immobilization extension, if there is a significant popliteal fossa edema, then
Hmm.
that can be problematic,
Yeah.
applying a in extension. So that is
So yeah.
one
So
factor
this
I would look at.
agree with you absolutely. And you can see on the left side there was quite a bit of swelling, and when a child sustains this injury, it's a high velocity injury. So surgeon probably applied cast in the flexion, applied the plaster, uh, and then patient came to us, and the mother. Yeah, Preksha, we can go ahead now.
Yes. So this was how the child presented to us. So he had a procurvatum deformity, a significant limb line discrepancy on the left side. So this,
So right side got healed well as it was looking very benign, but on the left side it ended up into this about a year down the line, and so the mother and family says that the discrepancy is progressing, and so as the procurvatum deformity. And can we zoom? And this is the X-ray, the fishtail kind of deformity. So Hitesh bhai, what is going on here?
Yeah, that is looking that definitely it is on the central, but we cannot comment because the it is limb is in flexion because there is a procurvatum. If you see the
Exactly.
lateral X-ray, the lateral X-ray is in procurvatum. So whenever we see, because central bar will show that the Harrison breath line towards the central part, which is not there. This is probably there looks like that in flexion.
Right.
The X-ray is there in flexion. Otherwise, typical physeal bar will see the all the joint line, the growth arrest line is towards the one physeal bar, but definitely central is lacking as compared
Yeah.
to the medial and lateral. That we can say.
There is a bit of sclerosis on the medial central side,
Yeah,
but as we routinely see the bars, we cannot visualize the bar on X-ray.
yeah,
Preksha, can you go back a slide and see the lateral view as Hitesh bhai? Yeah, Hitesh bhai, I mean, something is seen in the lateral view in the center, as you can see,
yeah.
but nothing in AP, probably because it's an even the maximum extension we have taken AP view, but it's still in flexion. Sandeep, what do you think?
Yeah, so exact details would be revealed on the MRI, but looking at the X-ray, this looks like rather than just being a localized bar, the other possibility is that this is a much more generalized involvement of the physis, which
Hmm.
corresponds to, the vascular damage to the growing physis. And therefore, there is avascular necrosis of the, germinal layer, which is resulting in this growth disturbance. So it is fully
Hmm.
possible that, you do an MRI, you may not see a clear-cut bar over here.
Hmm. 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 And
This
then
kind of, picture you see, more commonly in
infection,
infections rather than in trauma.
right? So what we should have, Preksha, we should have placed here is a comparative X-ray of the lateral view of opposite side. And
yes,
with,
sir.
as Sandeep said, if the physis is not good, then you see generalized reduction in the physeal space. Anyway, so now in that case, let's go on to MRI, right? That's what we
Yeah.
should do. And then we got an MRI. Yeah.
So
So these are the images, Sandeep. Can you comment on this MRI film now? If any delegate has some different view or input, just raise your hand or put in chat box and we'll consider it.
Yeah, this does seem to be there seems to be some localized bridging of bone in the posterior and the central aspect. So that does correspond to the deformity that we are seeing, central tenting of the physis with the procurvatum, and this child is pretty young, just around 6, 7. So,
Yeah.
so looking at these images, uh, I think every attempt should be made to restore the growth of the physis, because there does seem to be some localized bridging of bone.
So it's a posterior and central physeal bar on this CT and MRI, and uh, that probably corresponds with the clinical picture. That child is having a procurvatum and discrepancy. And do you think that other part of physis looks sick or it looks okay
There seems to be some reduction in the
in
physeal
the, yeah,
as compared to normal.
fair, agree
Uh,
with you.
but whether that physis has any growth potential will only be known once we remove that localized physeal bar, and then we just wait and watch. Having said, I mean, we are giving a chance over here. If we do a physeal bar excision, which
Hmm.
we should do considering the young age of the child, we are
Hmm.
just giving a chance, and then we have to wait and watch and see how it goes.
Right, Hitesh bhai, how would you manage this?
Yeah,
And
there is
how would you read this MRI first of all?
because there is a definitely on a posterior aspect there is a bar, but very well not visible. It's not like the invisible because it is the plane of MRI is not in plane of the leg, and that is the
Hmm.
reason it's not been visible in all the. Second part is their axial cut. If we take with the very
Hmm.
minimal cut like 1 mm or less
Hmm.
than 1 mm, then we can definitely pick up. If
Yeah,
we want to take the bar, particularly if we can see that the lateral and medial is growing, but the central and posterior, somewhat more
it's
on
not
posterior
growing.
and central, that
Yeah.
is not growing and it is visible. It's a typical like a fishtail deformity we
Hmm.
can see here. It's same in the lateral view also in the
Yeah.
MRI.
Yeah. Why invisible? Because whenever we do surgery, we do in our operation theater under image control, or
Yeah,
at the most in OARM. Now we can do surgeon OARM guidance. But
yeah.
again,
But
it's difficult to visual. That's why the title was given invisible in
okay.
operating room.
Yeah, no, no.
Now,
Sometimes what happens in a when we take about the MRI or anything like a tarsal collation or a bar, we need to take the MRI, and particularly it is very difficult and challenging to get the MRI in
exactly.
the plane of the
Yeah.
bar. That is a
Because sometimes under image intensive we are always worried that it is a complete excision was done or not and so on.
yeah.
Now let us first, do we think that bar excision is the ideal intervention, or we can do something else? Can we consider growth modulation, anterior growth modulation?
Anterior growth modulation only works if there is a posterior would be growing.
Or
Because
no, there are papers where for a peripheral bar people have done growth modulation and that bar breaks away, no, that has been reported.
But I think
So
yeah,
that's
but
more for a fibrous bar, on an MRI.
it's
If it is a fibrous bar kind of a thing, then probably
okay,
it will break.
so probably in
Bony bar, I'm
this,
not sure. Yeah.
agree. So bony bar may not get away with the physis, and the shortening will not be addressed, at this point. So we agree, and we also thought that we have to go and excise the bar. The problem is bar surgery itself are not very reliable, no, and many infected bars, they work well and traumatic they doesn't well. And now I didn't have confidence that how we will excise in intraoperatively, because on X-ray I'm not seeing anything. So how would you approach this, Sandeep? How confidently you will go in and operate upon this?
Yeah. So we are not privileged enough to have access to the OARM. So in this particular case, what we would do is on the basis of the MRI, we would calculate on the coronal and sagittal what is
Hmm.
the distance of the bar from the periphery of the physis.
Right.
Keeping that in mind, from the metaphysis, I would probably insert a guide wire into
Hmm.
that point, which is being seen on the MRI. Keeping in mind
Hmm.
AP view, how much it should be from the medial end, from the lateral end. On the lateral
Yeah.
view, how
So
much
it's
it should be
it's
from the
lot
port.
of extensive planning,
Yeah.
and it needs extensive what do you say, preciseness, and then you may end up excising a lot of things. Not you don't miss this. Yeah, Hitesh, bhai, how would you manage?
See, if the bar is less than 30%, that I think definitely we can have as Sandeep said, we can take in a metaphyseal window and
Yeah,
metaphyseal wire. According
yeah.
to the metaphyseal wire, we can see if it is there. We can burr and take out that only the calculator or calibrated part of the physis, and it will grow actually. This child is too young because 6 years old is another
Yeah.
10 years to grow.
Yeah.
So it would
The
be
only
good to.
only thing is the precision of what we are excising, and then
Yeah.
there are a lot of methods, putting a dental mirror and scope, and but I've tried. No, many a time it's difficult to assess. They
Visually.
are they are easier said than done.
Yeah.
So what we thought, and OAM access was not that easy at that point. So Preksha will show what we did. Yeah, Preksha, please go ahead.
So based on the MRI and CT images, the 3D printed jig was made for the particular bone model. So we used the facial physis as the reference point because that was something which we could
Can you be little
appreciate.
louder, Preksha?
Am I audible now, sir?
Yeah.
Yeah, so based on the CT images and MRI images, a 3D printed model of the bone was made and a jig was made precise to that. And we use the physis as the reference point because that could be appreciated under CM.
So, Sandeep, what we did based on MRI or the 3D engineer, he can make the facial volume and the exact size. And then on that model, they can calculate the angles. And then they ask from which side you want to go. And then we said, as it is more on the nearer to the medial side, we'll go from the medial side. And so he made a jig which will fit on the medial side of distal femur, and we asked them to make a circular multiple wire so that we can make a window, and through that wire we will remove that cylinder which will have the physeal bar. So we took the guide in that, and this is what model they made for us. And they put a, because they need a precise, because when you put, you don't know whether it to put little distal or proximal. So we made a reference wire.
Still wire.
A reference wire is going through the
The
physis
physis.
because we can see the physis on IITV. So, and that's how this was made. And Preksha, can you show images?
So these
So
are the
this is,
intraoperative.
yeah. So this is how this part was placed on the bone. It got completely flush.
So this
Then
was medial.
yeah, we went medial because it was a little bit more medial than central.
Okay.
And then we place the reference physeal wire so that the jig will fit and it will not migrate proximal or distal. And then between those wires, we made a window. That cortex of window was taken off to put it back again. And then with the help of burr and scoop, we removed the whole cylinder between the wires. You can show the intra-op images. Yeah. You see this? So we place the wires till the physis, and the area between this, we removed bird scoop till we reach the subchondral area under image intensifier, because that can be seen. And then usual, we put the fat graft and close the window. And we immobilize the child for 3 to 4 weeks. And yeah, Preksha.
So This was the preoperative radiograph where the limb length discrepancy was noted to be around 2.5 centimeters. At 6 months follow-up, the discrepancy was 1.8, and at 1 year follow-up, uh, the limb length discrepancy seemed to see that 1.8 centimeters. This was the pre-op lateral radiograph showing 35 degrees of recurvatum, which became 28 degrees at 6 months. And at the latest 1 year post-op follow-up, the recurvatum decreased to 23 degrees. And even on the X-ray, you can see the proximal migration of the white lines.
So it's procurvatum and not recurvatum. But as Hitesh bhai mentioned that this child is very young and is likely to improve. So we see this deformity is improving, and the discrepancy has reduced earlier, and now it has become static, but it's not progressing. So probably, and looking at these white lines, this bar excision surgery has worked. Sandeep, what do you say?
Yeah, that's a good idea. One thing that, so you basically use those wires as a guide. You removed the window in between those wires and then went
Yes,
in.
yes,
So other
yes,
thing you can do is the central wire, you can just design the jig in such a way that the central wire goes into the center of the physis
yeah,
and you kind of provide a sleeve. So over on top of that, you can just over drill
yeah,
with a drill bit.
exactly. So we can do that as we do in the CC screw guide wire kind of thing, no?
Yeah,
Yeah, so that is again a good idea.
yeah.
So, but because we wanted to remove that part and put something in, I thought that making a window will be a good option, but what you suggest is also a very good option. And when you remove that drill, you can scoop it and you
Yeah.
burr it and make a space for that. So that is again that makes life easier. Anyway, so I
So
think that this is,
photograph,
sorry,
photograph, what did you put?
yeah, fat. We place the fat. So yeah, so there is an indication. No, we read this paper later on. This was the idea came to my mind, but then we try as we are writing it up. Uh, there are paper of physeal bar resection using patient specific guide with for distal radius. They have done for this. But I think that the 3D printing is one of the indications for this sort of uh, what you say non-visible or difficult to visualize bars on X-ray. We can use 3D printing.
Yeah.
Thank you, Preksha. Let's move on to the next case. And Tashfin, would you like to any comment or question can be placed in chat box or raise your hand. Okay.
Am I audible, sir?
Yeah. Can you make the full screen your slideshow? Yes. Go
Good
to
morning.
the. So Dr. Tashfin was a former fellow, and he is now a consultant in Dhaka. Yeah, Tashwin, you can go ahead.
Good morning, everyone. Thank you, sir.
Good.
This is a 2.5 years old boy having a road trip accident, sustained injury over the right clavicle with multiple abrasion, and there is a bony bump on the right collarbone, and he had no head injury, and distal neurovascular status was normal, and it suggested that there is a injury over the right clavicle. So
Yeah.
this is an X-ray.
Yeah. So, Sandeep, this is a very unusual injury. Can you read this X-ray?
Very unusual. So, yeah, obviously there is a fracture in the mid shaft of the clavicle. Additionally, there is a dislocation of the sternoclavicular joint, and the medial fragment has just rotated, anteriorly.
Yeah, or
So very,
posteriorly. Very unusual sort of.
yeah, that will have to be assessed on the
Hitesh bhai,
clinically. It seems to be anterior or posterior. What?
or it's a middle shaft. So I thought that the distal fragment or lateral fragment would be sticking out through this near the skin. And yeah, Hitesh, have you seen similar injury?
No, this is unusual injury. However, when we see the clinical photographs, it is more on the medial side is anterior. We can see that the bump is palpable, not on lateral aspects. If you see, go back into the previous slide, so if you see at the junction of the neck, that fragment is anterior, not in posterior. You can see it's under the skin. It's rotated. Basically, it's a rotated injury, as well as the might be having a sleeve fracture on a medial side comminuted or sternoclavicular. That is injury. However, sternoclavicular injury which is going posteriorly, we are worried some, not anteriorly it's worrisome, but this is unusual injury, we can get it at CT scan, because it will give you the good idea whether it is compressing anything else, because it's rotated is unusual. And in between also one small piece is also there, we can see.
Yeah. So this is really unusual, and it's a baffling, how we would manage. And the first thing comes first is we have to do imaging and see the actual injury. So yeah, Tashwin,
Uh,
what imaging you did? Kindly show us.
we did a 3D CT scan, sir.
Hmm.
The This one is the first one. It's a showing that there is a shape fracture with the rotation with the separation at the medial physeal end of the clavicle.
Hmm. Was there any rib fracture associated, Dr. Tashwin?
No, sir. There is no refracture, sir.
But Sandeep, now we can see on this image the physeal separation. The sternal part of clavicle is facing behind, posteriorly, just above the scapula. Can you see that?
Yeah.
Yeah, so
So,
it's a very
could you
unusual.
see the medial physeal fragment? I mean, was this a dislocation or a fracture medially? At the medial at the sternoclavicular joint. Could you see the medial end of the clavicle? Was it?
No, it's a physeal separation.
So, no. So how do you differentiate between the two on a CT? So, would it be a better idea to do an MRI?
MRI, yes. In MRI also it's better, because we need to see whether it's compressing over any structure. But Tashwin, did you have chance to get an MRI, or
No,
you did the CT only?
we did CT only, sir.
So I think they did the CT and they were in touch with the CT surgeon, who was, they usually take decisions based on CT scan. And yeah, do you have another image to show, Tashwin?
Yes, sir. This one.
Hmm. So yeah, Hitesh Bhai said, it's like there is the prominent part which we could see anteriorly was the lateral part of clavicle, which was jetting out of the skin, and the whole medial segment was probably going posteriorly and inverted. So it's an extremely unusual injury, and fortunately, child did not have any rib fractures or any chest symptoms or any.
Any
Now, Hitesh
respiratory.
bhai, when we see this medial physeal separation of clavicle, what things we should keep in mind? What dangerous structures we should be watching clinically?
Basically on the arterial structure and lung, if it is because it's a physeal separation, it's a very important message. It's the last physis to appear and fuse also. So if a
Hmm.
transphyseal separation happens, and that one is generally remodeled, what Sandeep said is very important, whether it is a sternoclavicular dislocation or the transphyseal injury. Transphyseal injury, if you manage it conservatively, if it is not compressing any visceral structure, then it will be okay. But if it is endangering lung and the important vessels, basically it is on right side. If it is there on the left side, the main vessels also going out
Yeah.
of that will also get it compressed. So it's better idea to do the axial cut.
Hmm.
Axial, because this is 3D is okay, but when we take about axial, how
Yeah.
far it has gone posteriorly, that
Yeah.
is
That's
more
I
important.
agree. That's what I told. Uh, Now, Tashwin, do you have any further imaging, axial, or you don't have at this point?
Sorry, sir. I have no.
No, no issues. Will be evident and very dangerous, but brachial plexus injury will be subtle. So, was there any brachial plexus symptom, or child was moving the hand well? You said that, right?
Yes, sir.
Yeah. So, fortunately, brachial plexus was also saved in this child. So, he's a very lucky child. So Sandeep, how should we manage this? We cannot leave it conservatively, right?
Yeah, probably not. Considering, that this is probably, impinging on the vital structures. So I would keep a vascular and surgeon, obviously,
Very good. Yeah.
and a plastic surgeon with me. And then this would, need to be explored. All the vital structures would have to be carefully retracted out of harm's way. And that fragment, the medial end of the medial fragment, which is, impinging posteriorly, I would
Hmm.
probably just extract it from the soft tissue structures,
Hmm.
and then probably just replace it within the periosteal sleeve. Okay, there is going to
Hmm.
be a thick periosteal sleeve.
Right.
I imagine it must have torn posteriorly, probably. That will have to be assessed. And just replace it in the periosteal sleeve, and maybe then take, one or two or three tack stitches in the periosteal sleeve and close it. That should suffice for the healing of the injury. But the most important step is extracting it and protecting it from the neurovascular structures posteriorly.
And would you do any wiring for the clavicle fracture? Or you leave it alone.
No, clavicle fracture, probably I would leave it alone, because as I mentioned, there is going to be a thick surrounding periosteal
Right.
sleeve. I would not disturb. That would be sufficient to heal the injury.
Yeah.
And medially at the level of the sternoclavicular joint, if it's a sternoclavicular joint dislocation, then maybe put on one or two ethibond stitches, that would
Right.
suffice to just hold it in
So the
position.
most important thing you say, we should keep a CT surgeon together because we may not be well versed with that area, and we don't
Absolutely.
want any further, iatrogenic injury. Hitesh, bhai, how would you manage? You would agree with Sandeep, or you would do something different?
Yeah, I agree with Sandeep, but however, this is like a child has sustained the trauma, and after that, he has not got any neurovascular, visceral, or any other injury. But the concern is also here, it is anterior piece, which is just under the skin. So skin can break down also here. That
Hmm.
is also important because most of the clavicle injury on the medial side do nothing if it is anteriorly.
Yeah.
And if it is only the posteriorly, you can do the aggressive treatment. But here it
Right.
is different. It can
Yeah.
also cut out the skin also. That is
So the
additional point here.
yeah.
But
So
I
the
don't fix it. I agree
recommendation.
with Sandeep. I
Yeah.
agree with Sandeep. I can put the stitch with the
Right.
vicryl or ethibond. That's it. It's okay.
Right. So the recommendation for medial physeal separation is uh, if it is anterior and just a cosmetic thing, you don't need to treat. If it is posterior and it's compressing on important structure, you have to go in. Yeah, Tashwin, can you show what you have done?
Yes, sir. So we also went through the journal where it shows that they fix the fracture with the KVL and non-absorbable suture. So, and this type of case has not been reported till now. So we keep with us cardiothoracic surgeon under the anesthesia. We keep the patient in supine position with shoulder abduction and extrusion, and we incise over the clavicle. And after exposing, we found this. There is a fracture at the midshaft, and the proximal end is displaced posteriorly.
So it is going all the way
Medial
behind.
end, yeah.
Yeah, the medial end is going
Posteriorly.
behind. Yeah, and can you show the sternal end?
This is the sternal answer.
Okay. And there was no remnant of clavicle there. It was complete physeal separation, right?
Yes, sir.
Okay.
And luckily, there is a no vascular injury, which is behind of this fracture site.
Okay.
So then we uh, unfolded the fracture site, and then keep the medial end of the clavicle, and
Hmm.
take suture with a absorbable suture tied with a peristem slip, and
Hmm.
then we uh, reduce the clavicle, and the anterior peristem was also fixed. And after fixation, we take confirm the stability through the IITB.
So they have done exactly what Sandeep you said, the suturing of the medial hand and just stick the periosteum around because there's thick periosteal sleeve and they didn't put any wire. So yeah, good. Yeah, Tashmin, you can show the follow-ups.
And this is after 1 month. uh, and after 2.5 months.
Yeah, so the fracture has healed very well and so has the range of motion has also been restored.
Yes, sir.
So Tashmin, this is a very rare injury and you can write this up, it can
Yeah,
be,
wonderful case, wonderful.
yeah, can be considered as a case report. Hitesh
Okay.
bhai?
Yeah, good to have the report in that because it's the fracture dislocation, very rare injury. So injury, we need to find out what has happened, why does it happen like that. This is fracture as well as that's medial hand is rotated. What kind of injury is there? We can focus
Yeah.
more on that.
What would be the position of extremity while the child has this? That will be interesting.
Yeah.
Now we have few hand surgeons with us. So Preksha will take yours as the next case and Kunal's last because that hand surgeons probably Parag is there and they want to leave earlier. So hi Parag, good morning.
Good
Thank you.
morning. Good morning. Am I
Thanks.
audible?
Yeah, you are. So thanks for being there. Let us present a very
Pleasure.
rare, presentation and an eye-opening injury we came across recently. Yeah, Preksha, you can share your screen.
Yes, sir.
So we know that now these fun parks are open. In Gujarat, we had an incident in Rajkot. In fun park, there was fire. So for about couple of years, the fun parks were banned. But now they have reopened, and we see a lot of trampoline injuries, and now there's a new place to play. It's a ball pit where there is a pit full of balls, and one unusual thing happened. So Preksha, please take us through.
Yes, sir. Good morning, everybody. So we had a 4-year-old who went to a play area wherein she tried to retrieve the ball from the suction chamber, which is marked by the black arrow in the picture, and sustained injury to the right hand. Is it visible, sir?
Yeah. So this is the setup of this ball pit and this machine. So children, they put a ball here and ball will be sucked in and it will pass through this pipe and it will fall down. And it's a very pleasant sight for children. So unfortunately, this area is not supervised by parents, because they're small area and they don't allow.
For the children, I told you that actually they don't need supervisor.
Yeah, so that this kind of they can put this is a mechanism. So yeah, Preksha, go ahead.
So this was the sort of injury the child sustained. So initially, she went to a general orthopedic surgeon, wherein the parents were advised to get daily dressing and to see further. So when she presented to us, we had the dilemma to debride under anesthesia or not because we thought that there might be certain debris, grease, or something which might have still been inside the wound.
So can you show that presenting picture? Go back. Yeah. So Parag, how would you now child is doing movement, a bit of movement, but child was in pain. So um, we were not able to get all the DIP, PIP or MCP joint movement clearly. And X-ray is not, but the child has undisplaced fracture of the distal phalanx. So how would you take these children?
So, by considering the mechanism of injury, of course, this child requires first wound inspection under anesthesia. In that process, we definitely consider we don't remove the dermis, but we definitely give a clean saline wash. And we, rather than depending on his active range of movement at all joints, we better see the child's function, hand function under anesthesia. You are
So,
muted. Look.
yeah.
Okay. Yeah.
My,
Okay.
so the question, how would you check function under anesthesia, or you just visualize the wound, or
No. I would
what do you
definitely,
do?
because this is a twisting injury of the finger,
Yeah,
and any injury on the volar aspect of the finger, that too in the central location. And when you have a fracture, could be because of the twisting of the finger, but it could be definitely a tendon injury, So it is better to have inspection of wound under anesthesia when the child is comfortable and we are out of parents. So it is, and we take advantage of having a nice wound lavage or debridement.
exactly. So first thought which came to our mind, our patient went to an general orthopedic surgeon. He dressed it, and he said that there is an associated undisplaced fracture. You better take opinion of a pediatric orthopedician. And when
Hmm.
we asked the child was doing a little bit of flexion,
Yeah,
but I did not expect any other injury but to see this superficial injuries, and child is moving. So I was not suspecting any deeper thing down. And but as you rightly said that there was dirt and grease and greasy material, so we thought that we should debride it under anesthesia and do a good lavage and then suture it after removing the dead tissue if it is there.
correct.
So yeah, Preksha, please go ahead. What show us what we found? Yeah, Preksha, we cannot hear you. Can you be louder?
Hello.
Yeah,
Uh, Yeah, so under anesthesia, after thorough debridement, we found digital like FTP to be split in the index as well as the middle finger. So it was a clean transverse cut which occurred at the zone 2 of the hand. For this was level of injury which had occurred in the child. For which, what we did was we identified the proximal end, pinned it. And similarly, we did it for the index finger, and the two ends were measured using the Kistler's technique.
Preksha, can you go to the yeah? So Parag,
Yes,
now
sir.
yeah. So at our surprise, we found that there was a sharp cut injury at this level in not only in one but both the fingers, index and middle finger.
Yes.
So the thing which we thought it would be benign,
Yeah.
very severe injury it was.
Yeah. Even I suspected in the index, yes, but definitely I didn't suspect in the middle.
Yeah. So and
Okay.
something white popped out, during my first examination, and that from that time I had a doubt that hopefully. And so, how would you manage now? What sort of suturing you do in these cases?
So first of all, these wounds we need to extend proximal and distal by Brunner's approach till we are
Yeah.
very sure about visualization of the two cut ends of the tendon, as well as luckily the injuries are at the probably PIP joint where there is a A3 pulley. But
Hmm.
we need to maintain A2 and A4 pulley that every surgeon should keep in mind. And
Yeah.
unless you make a proper exploration proximal to distal, you will not be able to understand the intactness of the pulley. Second thing is, prior to the debridement, also we have to warn the parents that if we suture these wounds like this, they may have a contracture because these wounds are at the joint. So you
Yeah.
may have to consider a small local transposition flap if possible, or cover with the nice soft tissue and at least put a full thickness skin graft. It may not need a major flap or something, but
Right.
we need to inform the parents about it.
Right. So, fortunately, we were doing a nerve repair, plexus recon on the
Okay.
other theaters. So Nishchal Bhai was there.
Okay.
So I called him up, and we extended things a little bit, and we went with the artery force. We tried to pull the tendon underneath the FDP, FDS pulleys, FDS tendons, and we could deliver it. And then he
Okay.
freshened this up. took the sutures, and the skin was we thought at this point, does it need any flap or not? But we could close it easily
Okay.
without stretching. So, but he warned that there is high likelihood that child might develop
Contraction.
fibrosis and it would need a lot of rehab.
So
Yeah, Preksha.
did the child have two tendon injuries or one tendon injury?
No, one tendon injury, and that is, I think, FDP slip was
Okay.
cut. Fortunately, and that's why she could do some flexion.
Some flexion. Yes. Okay.
So this is something which I learned, that even if child is doing some flexion, and we think that child is not doing things because of panic situation, but you have to explore, because even though there can be a, yeah,
So I want to give one message in this case also. In a children, when we want to assess flexor tendon injury in the finger, that to open, you can squeeze the mid forearm musculotendinous junction with your thumb, and you can have flexion of the fingers. Okay, that
yes,
is how we also check the intactness of the tendon in children that press away from the zone of injury. So they are also confident. They will allow us to touch mid forearm or
right,
distal forearm. You can check on your own forearm. Just press the distal forearm with your thumb press, and you will see flexion of the thumb, IP, FPL, FDP function can be assessed. Okay.
yeah. So I mean, I agree with that point. The only issue is you can understand the panic,
I know. Yeah,
the
completely.
parents as well as the child.
Yes.
Yeah. So Preksha, can you show how? uh, Yeah, so Nishit by saying forearm compression test would be good. Yeah, agree.
Hmm.
So this was the final tendon repair, and as you can see, we did not have to extend too
Yeah,
much. We
yeah.
found it,
Correct, correct.
and it was we were unable to close it without much tension. So we did that, and it's just a month. So child is still in plaster, and we are doing passive flexion extension movement. And
Okay.
it's sometime we'll remove the plaster after 6 weeks. Yeah,
Okay. And you did not do anything for the fracture.
it was an undisplaced, so we plaster. The initial
Okay.
plaster was in this position, and
Yeah.
after 3 weeks we made so that parents can move. So
Yeah.
this is the position of plaster we
Yeah.
gave.
Nice.
Yeah,
Very, I mean, this is a good
uh,
message that these injuries can happen in the
so
kid's body.
that's why I sent to all my parental group, and the authorities should make some net or something so that child should not put hand inside the pit.
Yeah.
Because they are very curious and see. And this what happened, that machine got closed temporarily because of power
Yes.
cut or something. So child started, why it's not working? Let me push the ball in, and then it suddenly
My
started, and
God.
it did the cut injury probably.
Yeah.
Yeah.
Good. Good.
So Preksha, you have any literature to share, or there's less time so we can move ahead to the next case? And Hitesh bhai will need your help for that case. Thanks, Preksha, for sharing it.
Thank you, Dr. Maulin, for
Yeah,
involving
thanks
me.
Parag for sparing time. I realize that you are for your media team
Yeah.
meeting at
Yes.
Rishikesh.
Thank you so much. Thank you.
Enjoy river rafting there.
Yes, yes, did it yesterday. Okay. Okay.
Take care. Yeah, Kunal, you can share your screens. So we are moving to the last case of the session, and again, this was a bit confusing for us. Um,
Sir, am I visible?
Visible. Can you make a full screen? You're audible as well as visible.
Morning, everyone. In my case, a case of mysterious hip pain. Uh, the 7-year-old boy presented with the right hip pain, which was 4 days back. He had a fall from bicycle, after which he could walk. But on examination, we found that there was apparent lengthening on the right side and restricted abduction and internal rotation of the right hip with a limping gait. So we did the X-rays for the patient. He found out that the X-rays were normal, and so the diagnosis was made as transient synovitis of the right hip. As a result,
So yeah, now usually Hitesh bhai, this happens so that they come with a pain, limp, recent limp and restriction of motion as we see, and then they attribute, parents attribute that to some fall or some injury. So they say that for 4 days back he had a fall, but we typically ask after fall could he walk or not? Then he said yeah he walked, and from next day he had this problem. So we try to make sure that it is not due to trauma, although family would always think that. And this was a typical presentation of the transient synovitis picture we see. So
He was walking when he presented to you?
sorry.
He was walking when he presented to you?
Yeah, he was walking, but the typically we see a bit of limp and a bit of external rotation. And there was a little apparent lengthening. In very acute viral, we don't see apparent lengthening. It's a bit of deformity, which we see in a little long-standing thing. But that was not a big deformity. So
we can see the lengthening. In some of the synovitis, we can see the lengthening. In any case of synovitis, this position of ease would be there. It will be having lengthening. We can have it.
yeah. So
But
what I
there
meant
was
is
a
the
restricted
deformity.
aperture.
Lengthening can be seen, but deformity won't be there. So I agree. So apparent lengthening can be there because of effusion. Yeah. So did we did the right thing? We gave naproxen and say you come back in a week's time and we'll check it again. Well, he didn't have fever at this point. Hitesh.
Oh, is it having fever? Is it so?
No fever.
Okay.
No fever.
Yeah, then what I can say that in a case which is having the walking range of motion is terminally restricted, the blood count and everything is normal, give the rest and analgesic. That's okay.
Yeah.
Because
So
it's synovitis, definitely
exactly.
synovitis.
Yeah, Kunal. So
The patient got relieved of pain in 1 week. So he presented to us on the second visit, which was 6 months initial presentation. And
so that episode got over and the child was all well. Now he's presented again after 6 months, that he is having pain in the same hip and a similar limping. So now family is why it is happening over and over.
He has a history of pain of the right hip, sir, with the various body parts and joints being affected at multiple times. So we got the X-rays repeated.
So this is a very important point. This time family says this kind of pain is happening not only in the hip, but also in the various body parts on and off, which are self-limiting for last 3 years. And so it was puzzling that why this for 3 years some benign pain is happening, it goes away. But still again we got an X-ray this time. And can you show the X-ray, Kunal? Yeah, so Hitesh bhai, can you read it and what do you think it is now?
Yeah, we can see that is definitely there is the physis, which is the height of the physis is reduced in the right side compared to the left side. And the exposure is different, so we cannot comment on the sclerosis, but we can say that is the entire film is only the sclerotic, but then the height is reduced. We can think about something like it's happening like a long standing, and it is common in case of the repeated synovitis. And if the person has got the multiple joints pain, like a juvenile arthritis, juvenile idiopathic arthritis is common. It is common in some of the case, like a Perthes also is repeated synovitis is common. So it is.
Yeah.
So if the child, what generally we follow any cases, because we are there in Perthes zone, any child with the transient synovitis, we follow them actually the 3 months or 6 months. See the check range of motion. Don't say every time X-ray, but then they will be also presented like a repeated synovitis or recurrent synovitis.
So here we see this metaphyseal cyst, which we very commonly see in Perthes, right?
Yeah. But however, the X-ray should be having good quality to say it's a Perthes, because if you see the height is definitely less. We can see the one horizontal sides like subchondral. In a prog lateral, we can see the subchondral fracture. So it's a more higher chances of Perthes is there, but a good quality X-ray is needed
And
actually.
of course, you're commenting on we have seen this X-ray. The sclerosis is definitely there.
Yeah.
The lateral part of epiphysis, you see, it's sclerotic compared to the opposite side. So, would you stamp it as a Perthes disease? Should we? Yeah.
Yeah.
So that's what we uh, thought. And how would you manage? Now he's 6.5 years old, uh, radiologically Perthes with restricted motion. So we would try to give anti-inflammatories, right?
Yeah,
And
actually,
improve
it's
their
our this one is there between 6 to 8. If there is extrusion is less than that, so we treat it this non-weight bearing. I do not treat aggressively like this. It's a reassure the family. All the Perthes we need to rule out the other causes of AVN. Do the HB electrophoresis is not coming from sickle belt. Get that idea whether it is only Perthes or not.
So Mudit is asking that why Perthes disease would present with various joint and
Ex-
body
e-
pain since
e-
last 3 years.
That is reason I said
Yeah.
exactly that is we need to find out the other causes of it's not only the Perthes. Perthes is also diagnosis of exclusion. You can't say in the Perthes on only one X-ray.
Yeah.
Whenever there is idiopathic avian is there, only it will stem as Perthes.
So why not cecal or vasculitis? That's right.
Yeah,
And
we can say about HB like if it is coming from Panchmal district or any Dahod, it's possible to have the or like a Surat that it is.
so for all
So,
the
what is the set
fellows,
of investigations you advise in this case, Hitesh?
I advise the HB electrophoresis for every case is do the ESR and the CRP to the marker, rheumatological marker. Very simple test to find out whether it is Perthes or we are dealing with something else.
so it's in room. See, we have seen a lot of JIAs and hips, but what we see is they may have synovitis, but we have not seen this reducing height. Have you seen it frequently, Hitesh?
Yeah,
Reduction in the height of physis?
if sometimes rheumatologists have get the steroid, that's we have seen post steroid induced also. So it
Ah,
is
yeah,
so that is also there in all the condition. What is all described in all differential diagnosis of Perthes will present, but the MED and SCD will present separately, not on lateral pillar, on medial pillar and
mm,
central pillar. So that will be different in Perthes.
yeah. So yeah, and then MEDs can have a differential starting point on one hip than the other, and so you may see a reduction in height on one side, and after
Yeah,
some time on the second side. So
yeah.
I agree with that, and so patient had normal CRP, ESR. There was no morning stiffness. The family said that in morning he can go to bathroom and also. So that was a dilemma. And what is more important for all fellows is we must know what is the typical clinical duration for different stages of Perthes disease. Kunal, can you show that slide? And that's what we have been taught by Dr. John Wedge. That if we are following that modified Wanderstorm classification, yeah, Kunal, can you?
So the diagnosis was made as right hip Perthes modified Elizabeth Town classification 2A. According to Benjamin Sir's paper, we said that the modified Waterstone classification of the LCPD, we said that the onset stage is just for 4 months. Then the stage 1B is for early fragmentation. And the stage starts at almost 8 months post the start of the injury. And then it continues to 3A, that advanced fragmentation is found, and it continues for 8 months, and then the healing stage is reached after almost 36 months of total cycle.
So when we see an kind of early fragmentation in Perthes, the disease would have been about a year old because the AVN phase goes on for about 8 months. In this case, again, there's 3 years history on and off, which was not matching the radiological stage. Hitesh, bhai, what do you say?
No, it is okay because it is within a 6 months they will be actually when he presented the X-ray was totally normal.
Yeah.
And if he said that is subchondral fracture, when there is a subchondral fracture is there, it's a horizontal fracture, is not a 2A, it is 1B actually. The height is reduced compared
Yeah,
to the opposite side, and it's
yeah,
the first stage will be detected within 6 months to 8 months, and exactly it happened in this child. What we got it that it's a pre-existing synovitis was there and repeated attack. The child has got on and off pain, and that's how it is. This is a typical syncoropathy disease. It is very
yeah,
common to have in
yeah.
the
So that
stage.
is right. But what I was telling that then the family which is complaining that this kind of pain has been happening for 3 years,
Yeah,
it's
that
bit
is that
yeah,
is actually we can mix it with some of time with like a growing pain,
synovitis okay,
or sometimes is like a multiple osteochondrosis, which is also common. So it is there is various issues are there in this child, but the X-ray looks more or less similar to the
right.
pathies.
So
Then
now
that's
see, he is a 6.5, 7 years. Would you just conserve it, or would you like to do something?
no,
Uh,
in the 6 years well contained, and what our protocol is there, we do the perfusion MRI in that we find out what is the extent of disease. However, if before the without perfusion MRI, we can treat this child conservative because there is no extrusion, well contained, very well range of motion, and we can see AP and proglateral. There is no narrowing
no
of the
deformity,
obturator
yeah.
foramen, so we can treat this conservatively actually.
And the head at risk signs are they don't matter, right?
No.
Metaphyseal cyst and so on. But we planned varus derotation osteotomy, thinking that this might go whether there is big cyst and the disease extent would be lateral 75%, and it might. So our approach after listening to you and every time the different things, we have been doing VDRO for children more than 6, 7 years. So that's what we plan. But again, before we do VDRO, we make sure that there should be a good range of motion. Many a time if they are stiff and we operate, they will end up further stiffness.
Yeah.
So we ask them to uh, come back after 2 weeks, and then we'll consider where VDRO with GT epiphysiodesis. And patient was sent outside my waiting area. But my fellow came back that, sir, this patient is having excruciating pain now in the humerus, in both the wrist and also the chest wall. Suddenly, after in my OPD, my consulting room child was okay, bit limping. So he went out walking, and then he started having sudden pain. So I thought that this child probably has uh, probably has some psychological thing that as we discuss surgery, he has kind of hysteria and he's having complaint because this pain was excruciating. So I asked them to sit in, give them some room and gave some oral combiflam. But after 15 minutes, again, he was still in severe pain. And we had to give IV analgesia to this child, and he got relieved after some time. And as he was showing some shoulder pain, so we got an X-ray of humerus and all, but that X-ray was normal. But at the night, once his pain got off, I asked that you go back and see your pediatrician and get it checked, everything, before we consider the surgery. So the patient went to pediatrician, so the HB level was low, and he advised peripheral smear. Now again, this patient was from Dahod area, Hitesh. So, and then he was showing sickling, and this patient was referred to hematologist. And as you said, they have done this HPL electrophoresis, and that also confirmed sickle cell thing. Now, the surprising thing was the child did not have any blood transfusion before or any sickle cell crisis before this. This sort of severe pain happened, and we learned in a hard way. Like many a times, we kind of do not take much leverage to the the history. But my fellow digged into it, Kunal, and said, sir, he had a elbow X-ray before and he had a shoulder X-ray before. So he had substantial pain with normal X-ray, which general orthopedic colleagues They gave analgesic for some time and it relieved. But no one ventured into investigate further, neither me. I was thinking this simple Perthes, and it turned out to be sickle cell with AVN now as a diagnosis now.
We
So
tend to
now
dismiss
question
them as growing pains, but we tend to dismiss them as growing pains. But I think
exactly. Yeah.
if the recurrent such episodes are there, we have to keep this in the back of our mind.
And
Yeah,
would
but
he not have
our protocol is there. We never stamp any case of Perthes. All the 1,000 cases of HB electrophoresis is done. Every single case HB electrophoresis is done. It's by rule. Without that, we never proceed anything. Perthes is the diagnosis of exclusion. If there is anything is there, everybody thinks the Perthes is that all avian in kids. All
So,
avian in
Hitesh,
kids.
what might be the incidence, that you
yeah.
see X-ray of
Yeah,
Perthes? What might
yeah.
be the incidence that it actually turned out to be sickle cell related?
Yeah. No, we do see sickle cell also. When I was in Surat, there are most of the cases are from sickle cell. It is in Jalgaon area, there are a lot of sickle cell disease. As I said, Panchmal and Dahod, there are a lot of sickle. That's why I told already. I was not aware about this case. But when I said if patient is from Panchmal and Dahod, I don't proceed anything other than sickle
Yeah.
cell.
So at
Definitely.
least Sandeep, I feel that if patient have previous history of pains,
Yeah.
so there is a possibility, we when we think of sickle, we think that this child would have already sickle cell crisis sometime, would be been transfused, but it's not that. The first episode can happen when they come to you, and when they have previous history of multiple pains. Now I learned that we have to get this investigation done. Now,
Yeah.
Hitesh, by now there's sickle cell and AVN. How would you treat it?
Yeah, I will treat it conservatively. Reason is that it's well extruded because sickle cell cannot be treated like Perthes disease. The sickle cell is different because there are repeated attack can happen and repeated AVN can lead to the issue. So the sickle cell prognosis is not as equal to the Perthes. However, if the child will showing any sign of the poor prognostic sign, we can intervene by doing about drilling on the physeal to get
Hmm.
the good
So core
vascular.
decompression kind of thing, right?
Yeah, yeah.
Yeah. So yeah, so we saw these papers, but I thought again, that the things were not matching. So the hematologist said that although this patient is having sickle, he has never been crisis. Even at this point, hemoglobin was okay, so he didn't transfuse. And I was still confused. So I did VDRO, and hydroxyurea has been started. Uh, and we
Okay.
are watching this, and then we read all the papers, and my fellow said that there is only one paper is mentioning sickle and Perthes kind of change VDRO. Rest all papers are showing core decompression. And sometimes if there's significant collapse, you do fibula strut grafting also if it is collapsing.
Yeah.
So these are very interesting paper Kunal will share. Can you go ahead, Kunal?
First of all, the question arises that will the course of the disease be different with sickle cell disease with Perthes? The question was answered by this paper by Raju Vaishya sir, and it showed that the femoral head is most common site of avian in sickle cell disease, with the entire epiphysis involved in sickle cell disease, which was different from Perthes as it involves only the weight-bearing areas. And so the resultant of treatment for sickle cell disease varies other than the Perthes. The other orthopedic manifestations of sickle cell disease include osteomyelitis, leg ulcers, growth retardation, dactylitis, fractures, osteoporosis, vertebral prolapse, which that should be kept in mind while dealing with a sickle cell disease patient. Next was the Harry Kim paper in JPO, which J. Posna. We found that the disease, even after being treated as a single hip, which can involve the second hip, even if the X-rays doesn't show initial a collapse or involvement of the hip joint, it will lead to almost 75% patients will have a secondary hip involvement. We can have other treatment options, including bisphosphonate therapy, core decompression with multiple drilling, bone marrow aspirate concentration injections, femoral or pelvic osteotomies, fibular stud graft or morcellized cancellous bone graft, hip fusion, and total hip arthroplasty. We also found that there is a new treatment option for femoral head osteonecrosis in sickle cell disease with the use of bone marrow derived mononuclear cells, which is a concentrate type of bone marrow or aspirate taken from iliac bone to prevent early total hip replacement for the patient. It can also improve the gait quality of the patients while being on initial treatments.
Right. So, uh, yeah, and that's the final paper,
Long-term clinical follow-up for the patient managed on conservative and operative treatment for at skeletal maturity for sickle cell disease was described by this paper in 2018, which showed there is a good functional outcome seen with femoral varus osteotomy or triple pelvic osteotomies. And there is a short-term follow-up study that they did for multiple drilling and autologous bone graft infiltration, bone marrow infiltration, which showed improvement in the gait as well as the condition of the hip joint.
So the key is we have to very closely follow these children, and as Hitesh Vice said, no, if it is showing the sign of collapse and extrusion, we have to intervene. If it is not just the collapse, you can do core drilling, and if it is extruding, we can do. There are still reports that you can do femoral osteotomy. So Hitesh, has a question: will perfusion MRI show any difference in sickle cell compared to Perthes?
No, but the sickle cell, the pattern of avian is different. We can make out that, but that is not only the way we can say it is a sickle cell. Because you see, the perfusion MRI will say the extent of the avian, not a type of avian.
Right. So we have done VDRO in this case, and what we should keep in mind, and how we will be, of course, following every child we follow every 3 monthly or
Yeah,
4 monthly, but
we need to follow up. We need to find out should not happen the repeated avian. That's difference between sickle cell and avian. We'll have the repeated avian in sickle cell because we don't have control on the blood. Where the Perthes is self-limiting, where the sickle cell is not self-limiting. That is reason it is not described much on video because virus will lead to the how much virus will remodel we don't know because this is young, so this will remodel in this child. But if there is again collapse and avian happens,
at
then
an
we'll back to the
advanced
square.
stage.
Yeah.
Yeah. Yeah. So this we have asked them to be in constant touch with hematologists now, so that they receive hydroxyurea and whatever management they can do and avoid any crisis.
Yeah.
So I think we shall conclude today's session here. Thank you, Kunal, Preksha, and Tashveen for yeah, you can show this for nice presentation. Thanks, Sandeep and Hitesh, for valuable inputs. And
Good day.
Hitesh can conclude about the cases and will depart.
That's fine. All the cases were good. Basically, that's that good learning message that anybody can make a mistake, but that is very important to learn that. Find out for the diagnosis. First case is there for the complication, very different. Second was there is a the hand injury, which is also is a very different. The facial bar was central, and it's very different. One only message: the traumatic facial bar will have better result than infective. That is another
Yeah.
point that is also there. So it is having
Yeah.
good. And the last case is all the sickle cell, not to rule out in any case of avian. Thank
Yeah.
you. See,
Yeah,
good.
Sandeep,
Nice to
final
see you.
words, and we will conclude.
No, excellent cases overall. Thank you so much.
Yeah.
Unusual cases. And I think, each case can be written up as a case report, especially the case number 1 and case number 2. Uh, sick,
Right.
the clavicle and the
Bar
central
five.
facial bar.
Yeah. So
Thank you.
Preksha and Tashveen, you can write, and then pre-submission preview, you can have review from Sandeep and Hitesh, and they'll help us. So have a good day, everyone. We'll
Okay.
meet
See you.
Thank
again
you.
next Saturday with something more
Bye.
different and interesting. Have a good day. Take care.
Bye.
Yeah. Bye-bye.
Bye.
Bye. Thanks, Sandeep.